بسم الله الرحمن الرحيم. أهلا وسهلا بكم جميعا. السلام عليكم ورحمة الله وبركاته. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم أجمعين. اللهم انفعني بما علمتني وعلمني بما ينفعني وزدني علما إنك العليم الحكيم. اللهم أخرجنا من ظلمات الوهم وأكرمنا بنور الفهم وافتح علينا بمعرفة العلم وسهل أخلاقنا بالحلم، آمين وأجمعين. اللهم ارزقني نعمة الإخلاص لوجهك الكريم بكل ما أقول وبكل ما أفعل، آمين رب العالمين. My case discussion today about this patient incidentally discovered with the for chest X-ray, incidentally discovered the lesion. As we see here in this X-ray, this is a chest BA view. In this chest X-ray, we have one question: is there any mass lesion in this X-ray? Any question, any answer for this question? Is there any mass lesion? Yes or no? The answer of this question is yes. The answer of this question is yes. So there is a mass lesion in this BA chest view. The second question: where is the mass lesion? It is in the right apex, in the left hilum, and the left apex. Where is the mass lesion? It is in the right apex, left hilum, left apex. Take some few seconds to answer the question. The question is, the answer of the question is the left apex. The mass, it is in the left apex, as we see here. The mass, it is in the left apex. Now we shift to the next question. The next question is, what is the relation of the mass to the clavicle? What is the relation of the mass to the clavicle? It is anterior or posterior? What is the relation of the mass to the clavicle? What is the relation of the mass to the clavicle? This is the relation of the mass to the clavicle. It is anterior or it is posterior to the clavicle. Take a few seconds to answer this question, and let us see. So the relationship of the mass to the clavicle, it is the mass, it is silhouetting with, not silhouetting with the clavicle, and the mass, it is seen through the clavicle. So the mass, it is posterior to the clavicle. This is the clavicle here, and it is anterior, and the mass, it is posterior to the clavicle. We move to the next question. What is about the mass? It is spherical, it is oval, it is lobulated. What is about the mass? It is spherical, it is oval, it is lobulated. What is about the mass? It is spherical. This is the mass here. It is spherical, it is oval in shape, it is lobulated in shape. It is oval, it is lobulated. What is so the mass? It is spherical. Okay, we can stop the bowling, and the mass, it is spherical in shape. It is looks like rounded mass lesion in the left apex. We can move to the next question. The next question is, the mass is, it is irregular strands. Is there any strands around the mass? or in the periphery of the mass, or it is smooth. So the mass either smooth or irregular. Please vote. So the mass, it is, take a few seconds for the answering the question. The mass, it is the answer of the question. The mass, it is irregular. We see this is the mass here, and we see some strands around the periphery of the mass. It is in the inferior aspect here, and it is in the superior aspect here. So the mass, it is irregular. We move to the next question. That irregular strands of the mass, what is the name of the signs? It is corona radiata sign, it is a pleural tail sign, or both. What is that irregular strands around the mass? It is corona radiata sign, or pleural tail sign, or both. What is the irregular strands around the mass? Please name the sign. And please name the sign. What is the irregular strands? Either it is corona radiata sign, or pleural tail sign, or both. So the answer is both. We have the corona radiata sign and we have the pleural tail sign, as we see here in the peripheral image. This is the corona radiata sign, this is irregular, and we have some strands going to the left apex. So we have the two signs here. The next question, what are the other findings of this the patient has? The other finding the patient has: the patient has other finding. Patient has other finding: hyperinflation, vertical heart, or both. And we have the answer here: both. The patient has hyperinflation, COPD changes, and we have the vertical heart. Some question, it is asked about is there any mass in the left hilum? Yes, there is a prominent of the left hilum. The left hilum is here, it is a prominent, and we have strands around the going to the left hilum, and here it is left hilum. We should do CT scan to exclude any lymph node enlargement in the left hilum. The next question: is there emphysema of this patient? As we said, is there emphysema of this patient? We said we have hyperinflation, Is there is emphysema in this patient? This is the CT scan of this patient. Is there is any emphysema in this patient? Yes or no? We have take a few seconds to answer the question. We have emphysema or not, there is no emphysema. Okay. The answer of the question, there is emphysema in this patient. We have here paraseptal emphysema here, and we have here around the trachea paraseptal emphysema, and so we have paraseptal emphysema in this patient. And we have the mass lesion here. We see it in the plain film. So we have the paraseptal emphysema in this patient. We see the corona radiata sign. This is the corona radiata sign of the mass. This is irregular strands arising from the mass, and it is giving the corona radiata sign. And this is the yes, the answer is yes, it is a corona radiata sign. And this here, it is here corona radiata sign, and this here, this is the pleural tail sign. As we see, there is a line extending to the pleura in this patient. And also we have another satellite nodule here in this patient, and here some thickening, giving the suspicious nodule in this patient due to likely metastasis. What is the air bubble sign? This is, as we see here, we have in the superior aspect of the mass, we have two air bubbles, and this is air bubble sign, and it is seen in this patient. And the air bubble sign can be seen in the benign condition and can be seen in the malignant condition. Benign condition like hydatid cyst. In the malignant condition, we see it in the adenocarcinoma of the lung, as in this patient. So what is corona radiata sign? Corona radiata sign, as we see, it is irregular strands due to correspond to desmoplastic reaction, but the tumor invasion can be present, and this is malignant process for this suggested highly of malignancy in this patient because of the corona sign. But the pleural tail sign, sometimes it is fibrotic, and it is not specific for malignancy. The pleural tail sign, this is also reflect presence of fibrosis and can be detected equally with the benign and malignant formation. Concerning malignancy, corona radiata sign is more specific for malignancy than the pleural tail sign. Here, this is the CT scan of this patient, and we see hyperactivity of the mass, and the mass, it is also some desmoplastic activity around the aortic arch, as we see here. And the biopsy of the mass, it is adenocarcinoma. PET scan, it is positive if it is more than 1 centimeter, and it is positive result in about 97% sensitive and 82% specific for malignancy. We have false positive patient with sometimes with TB, sometimes with sarcoidosis, and sometimes with rheumatoid nodule. And we have false negative if the lesion is less than 1 centimeter, and it is also occur in the false negative in patient with carcinoid and with slowly growing adenocarcinoma subtypes. Tumors of the lungs can be classified as small cell carcinoma, and this is originate from the submucosal neural endocrine cells, and it is rapidly spread hematogeneously to the lymph node and behaves as a systemic disease, and it is usually disseminated at presentation. Non-small cell lung cancer, we have three types. We have the squamous cell type, which arises from the airway epithelium; large cell type, which is a typical cell that appear large under the microscope; and we have adenocarcinoma arising from the bronchial glands. And here we have the types of the lung cancer. We have the adenocarcinoma, and it is constitute about 30 to 35%, and it is peripheral. Cavitation is rare, and the smaller can arise with scar tissue, and it is a small tumor less than 4 centimeters. We have a pleural effusion. Squamous cell carcinoma, it is account about 30 to 35%, and it is decreasing. The adenocarcinoma, it is increasing, now the most common lung cancer, and it is here central. And the squamous cell carcinoma, it is the most commonest lung tumor to cavitate. Large cell tumor, it is accounts about 10 to 15%, and it is peripheral in location. Small cell carcinoma, it is about 20 to 30%, and it is central in location. And most aggressive tumor and the fastest growth rate, and usually disseminate at the diagnosis. Early and even massive mediastinal and hilar adenopathy in about more than 75%, and we have collapse consolidation of the peripheral lung, and it is chemotherapy, it is sensitive. We have a new classification for the adenocarcinoma. We have a pre-malignant type. We have a typical adenomatous hyperplasia, and we have the adenocarcinoma in situ, and we have the malignant adenocarcinoma. We have the minimal invasive adenocarcinoma, and we have the lipidic predominant adenocarcinoma, and it is more than 5 millimeter invasion, and we have invasive mucinous adenocarcinoma, and it is previously known as bronchoalveolar carcinoma. What are the risk factors of the lung cancer? We have tobacco, and it is about a 20 to 30-fold increased risk, and has greatest association with squamous cell carcinoma, and the weakest association with the bronchoalveolar carcinoma. We have other factors like asbestosis, interstitial pulmonary fibrosis, and radiotherapy are additional risk factors. The clinical presentation of the patient with lung cancer, in about 25%, it is about asymptomatic. We have symptomatic patient. We have recurrent pneumonia due to obstruction. We have cough, wheezes, and hemoptysis. We have the paraneoplastic signs, syndromes, Cushing syndrome, ADH secretion, carcinoid, hypercalcemia, and we have a prognostic features: hoarseness of voice, chest pain, brachial plexus neuropathy, superior vena cava obstruction, and dysphagia. Thank you for very much for listening, and hoping to see you soon in another talk. سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك. Thank you very much, and hoping to see you soon in another talk. انتهز فرصة قرب حلول عيد الفطر السعيد المبارك، وكل عام وأنتم بخير. I seize the opportunity for Eid and Eid Mubarak for